Welcome to this explainer. Today we're diving into a really fascinating and quite serious medical condition called bronchiectasis. We're going to look at exactly what happens when the vital airway pipes in our lungs suffer a permanent structural failure. It's literally a breakdown in the very architecture of our respiratory system. And understanding it means we have to look closely at both the plumbing and the biology of our lungs.
Here's our roadmap for today. 1. Defining the damage. 2. Etiology and pathogenesis. 3. Clinical presentation. 4. Diagnostic evidence. And 5. Managing the breakdown. Let's jump right in.
Section 1. Defining the damage.
So, what exactly is bronchiectasis? Well, it's defined as an irreversible, abnormal dilation of the cartilage-containing airways, specifically the bronchi or bronchioles. Now, the absolute crucial word here is irreversible. We aren't just talking about a temporary bout of inflammation like you might see in acute bronchitis. No, this is a permanent architectural change in the lungs. It's an actual destruction of the muscle and elastic tissue that usually gives our airway walls their structural integrity.
Based on what's known as Reed's classification, this structural damage basically takes three distinct shapes. First up, there's tubular, or cylindrical bronchiectasis, characterized by a smooth, uniform dilation of the bronchi, and this is by far the most common form. Second is the varicose or bulbous type, where the bronchi are dilated but with multiple indentations, so it almost looks like a bumpy string of pearls. And finally, we have the most extreme form, cystic or saccular bronchiectasis, where these dilated bronchi actually terminate in dramatic, balloon-like, blind-ending sacs.
Now, the actual extent of this damage can really vary from patient to patient. You can think of diffuse bronchiectasis as a widespread, generalized collapse, usually hitting the lower lobes and affecting both sides of the chest. Focal bronchiectasis, on the other hand, is much more like a localized bullseye. It's restricted to just one specific segment of the lung. This focal damage usually pops up when there's a physical obstruction in the airway, like a parenchymal tumor or maybe a foreign body someone accidentally inhaled.
Section 2. Etiology and pathogenesis.
We can pretty cleanly split the primary suspects behind this damage into two categories: congenital and acquired. Congenital causes are, of course, issues a person is born with. The most famous example is cystic fibrosis, but this group also includes ciliary dysfunction syndromes, like Carter-Jeter's syndrome. That's where the microscopic hairs that sweep our airways just don't work properly. Then we've got acquired causes. These are traumas the lung takes on during life, maybe a really severe bout of childhood pneumonia complicating whooping cough or measles, pulmonary tuberculosis, or, like we just mentioned, inhaling a foreign object that gets lodged in the airway.
So how does it actually happen? Well, it's a cascading failure, often explained by a mix of interlocking theories rather than just one simple mechanism. The obstruction theory suggests that an initial blockage messes up the lung's clearing mechanisms, which leads to pooling secretions and secondary infections. Meanwhile, the infection theory points to chronic, necrotizing inflammation that literally weakens and destroys those airway walls. Throw in the traction theory, where fibrosis or scarring in the surrounding lung tissue actually pulls and stretches the bronchial walls outward, and the atelectasis theory, where negative pressure from collapsed lung tissue expands the bronchial tubes. Ultimately, these factors all combine into a vicious, interlocking cycle of impaired clearance, pooling mucus, and chronic infection.
Section 3. Clinical presentation.
Imagine waking up and spending your first 2 hours of the day in a violent, uncontrollable fit of coughing. Why does this happen? Because the absolute hallmark of this disease is a severe, persistent, and chronic productive cough that develops into extreme paroxysms precisely in the morning. See, postural changes overnight allow pools of pus and secretions to slowly drain out of those dilated, cystic, or tubular pockets. They drain right into the main bronchi, triggering a massive coughing response the second the patient stands up out of bed.
The clinical fallout from this is surprisingly severe. Patients produce copious amounts of thick, tenacious sputum, and it's often terribly foul-smelling because of anaerobic infections pooling deep in the lungs. They also frequently experience hemoptysis, which is coughing up blood. This happens because the blood vessels along the walls of these dilated bronchi become super thin, fragile, and easy to rupture. You'll also see pleuritic chest pain and halitosis, or bad breath. And, in a rather fascinating medical curiosity, about 7% of cases lead to pan-digital clubbing, a bulbous swelling of the fingertips linked to chronic oxygen deprivation and persistent lung suppuration.
Interestingly enough, there is a notable exception to this presentation, and it's termed bronchiectasis sicca, or dry bronchiectasis. This usually happens in the upper lobes of the lungs, very often following a bout of tuberculosis. The irony here is that because the damage is up high, gravity actually acts as an advantage, constantly aiding drainage. Because of that, the patient doesn't have that copious, nasty sputum production. In fact, they might be relatively asymptomatic, with their only real manifestation being repeated episodes of hemoptysis, just coughing up blood without the mucus.
Section 4. Diagnostic evidence.
Now, even before we bring in the high-tech scans, simple bedside investigations can be incredibly revealing. There's a wonderfully visual, if slightly gross, medical test where you collect the patient's sputum in a conical flask and just let it stand. Over time, it separates into 3 distinct layers: a top mucoid layer, a middle mucopurulent layer, and a heavy, pus-filled purulent layer right at the bottom. Furthermore, simple auscultation, just listening to the lungs with a stethoscope, will reveal characteristic bilateral, coarse, leathery crepitations, basically crackles that reflect the massive amounts of secretions trapped in those deformed pipes. But to truly see the permanent damage, we have to jump from those crude bedside tests to high-tech visualization. Standard chest x-rays, unfortunately, just lack the sensitivity we need for this. Instead, high-resolution computed tomography, or HRCT, is the absolute gold standard and the imaging modality of choice. This scan gives us beautifully detailed cross-sections of the lung tissue, letting us directly visualize the structural failure. We can clearly spot the dilated airways and those cysts that definitely shouldn't be there.
When radiologists look at these HRCT scans, they're hunting for some poetic but incredibly precise visual clues. They look for parallel tram tracks, which represent the thickened, inflamed walls of the dilated airways. But the most famous visual cue is the signet ring sign. Normally, an airway and its accompanying blood vessel are roughly the exact same size. But in bronchiectasis, the dilated bronchus balloons out to at least 1.5 times larger than its nearby vessel, so it looks exactly like a ring with a jewel mounted on it. You're also going to see an absence of normal bronchial tapering as the airways reach the edges of the lung, and of course, those telltale cysts.
Section 5. Managing the breakdown. Because the anatomical damage here is irreversible, management is fundamentally all about controlling symptoms and aggressively stopping the disease from progressing. And it follows a really strict authoritative sequence. Step 1, treat the underlying cause if at all possible, like pulling out an inhaled foreign body. Step 2, improve bronchial hygiene and secretion clearance. This is huge. Using techniques like postural drainage, we physically use gravity to help the patient empty their lungs. Step 3 involves targeted antibiotic therapy to violently clear out those pooling infections. Step 4 uses anti-inflammatory therapy, like inhaled steroids, to bring down the swelling. And finally, Step 5 is surgical treatment, but that's strictly reserved for highly specific refractory cases.
When planning this out, there's an immediate critical split in our approach based on the extent of the damage. If the bronchiectasis is localized, say to just a single damaged lobe that won't stop bleeding or getting infected, surgical resection of that specific area might actually be the best option. However, if the disease is generalized across both lungs, surgery just isn't viable. For generalized disease, the entire focus shifts heavily to rigorous daily bronchial hygiene, treating flare-ups with 7 to 10 days of oral or IV antibiotics, and using bronchodilators to clear out any obstructions.
And that brings us to our final thought for this explainer. Since the architectural damage of bronchiectasis is, by definition, totally irreversible, is our only real hope to meticulously manage the lungs' plumbing before that vicious cycle of infection truly takes hold. It really forces us to reflect on the gravity of permanent structural lung damage. It's not just about surviving an infection, it's about the critical importance of early, relentless management, the daily postural drainage, the prompt antibiotics, to preserve whatever lung function remains. Thank you so much for joining me to explore this structural breakdown. Keep questioning, keep learning, and I'll catch you in the next explainer.